Dr. Burke, in terms of BTK inhibitor-based therapy, what can we expect in the relapse setting in general from a BTK inhibitor-based therapy? And we talked a little bit about first-generation ibrutinib versus second-generation compounds, but maybe what can we expect if we put a patient who's been previously treated, maybe BR? Most of the trials that have been done have enrolled in the relapse setting patients who had prior chemoimmunotherapy. So in that setting, what can we expect with a BTK inhibitor-based therapy as a relapse treatment?
Yeah, I think if you look to the data, I mean, the original study that we have the longest follow-up with is Resonate, and you know, that compared ibrutinib with ofatumumab in patients previously treated with chemoimmunotherapy, and the long-term follow-up was published last year, and they reported a median PFS with ibrutinib of 44 months. So say just under 4 years would be sort of the median PFS. Median overall survival was a little over 5 years. And so, yeah, I think that's the best sort of long-term follow-up data that we have with ibrutinib. With acalabrutinib, we have the Ascend trial that compared acalabrutinib with the control arm, which was a mix of either bendamustine, rituximab, or idela rituximab, and we saw improved PFS with acalabrutinib in that trial. So I think, you know, for patients who've been treated previously with chemotherapy, you know, either a BTK inhibitor or the venetoclax obinutuzumab combo, venetoclax rituximab combo is really the way to go over, you know, salvage chemotherapy. I have seen, you know, I saw a patient not that long ago who'd previously been treated with, I think, fludarabine-based chemotherapy and then had relapsed, and saw a doctor that recommended BR, and I sort of cringed a little bit because, you know, we now have data that I think that patient would be better served by either a BTK inhibitor or ven rituximab. So just, I think that's a key point for practitioners to know, that those are really the standard approaches now for second-line therapy after previous chemoimmunotherapy. And the median you know, PFSs are in the range of 4 years.
In the relapse setting, what's the population of patients who are who you worry about? Are you still worried about 17p, even though we do know that the targeted therapies have activity in patients with 17p deletion mutated TP53?
Yeah, I think we know that those with 17p and TP53 aberrancies still fare less well than those who do not have those in the relapse setting. You know, I think most of the other gene mutations seem to be having less prognostic importance. I think that's true in the untreated setting as well. In the previously untreated setting, there was a publication in Blood just 2 months ago based on CLL 14 showing that you know, venetoclax really seems to overcome some of the adverse prognostic implications of, say, deletion 11q. That the only really FISH abnormality that conferred a less favorable prognosis with upfront therapy with ven/obin was 17p or TP53 aberrancies. So I think that's it's true that these targeted agents are overcoming a lot of the other adverse prognostic genetic factors, but not 100% overcoming the 17p problem.